Good afternoon, ladies and gentlemen. We will call this meeting to order. We have a little bit of business to take care of. First, let me call the roll. So, Madam Clerk, if you would, I'll do it for you.
Chairman Boyd, Chairman Byrd, Chairman Freeman, Representative Hall, Representative Jernigan, Representative Kumar, Representative Marsh, Representative Sherrill, Representative Smith, Representative Terry. Chairman, you have a quorum.
Thank you, Madam Clerk. Do we have any personal orders today? Dr. Terry, you're recognized.
Thank you, Chairman and Committee. I just would like to recognize Ethan Weber. He's with Tennessee Eagle Forum. He's been shadowing me today and learning about what we're doing up here. So welcome him. He's also a constituent, so thank you.
Welcome. Further personal orders?
Unless they're presenting a bill.
Okay. Yes, Representative, Chairman Sherrill, you're recognized.
Thank you, Chairman. We did have some leadership members from Warren County here today, and I don't know if they've made it in or not. But have we have any here? Anyway, we wanted to welcome you if you're made it into this committee. Thank you.
Yes, welcome to all of you. We do have, if no other personal orders, we have some orders of the operation today. We're going to announce bills that have been rolled, but first I was told by the Speaker's office that we're to restrict people standing against the wall unless you're waiting to be a sponsor of a bill, and other than that, we will move forward. We have a doctor of the day, Dr. Amy Gordon Bono, MPH, if you'd like to stand and let us make you welcome. Thank you, Dr. Bono, for your service. We will move on to do a little housekeeping. We have several bills that have been rolled or taken off notice. Item number 37, House Bill 2486, has
Special calendar.
yes has been had the limit of its calendaring here in the committee, so we're rolling that to a special calendar to be considered at the heel of our final calendar. Item 38, House Bill 2843, is rolled. Is off notice. House Bill 2841, that's item 39, has been taken off notice. Item 41, House Bill 449, has been taken off notice. So we will move on. We have a calendar for today. We'll move on with item 1. And that's House Bill 2665. We have a proper motion and second on the bill. It is delivered to us by Dr. Terry. You're recognized on 2665, sir.
Thank you, Chairman Committee. This is essentially a COVID omnibus cleanup bill that Speaker's running to provide some clarity. And there is an amendment that makes the bill, Amendment 14705.
We need a motion and second on the amendment.
Second.
We have a proper motion and second on the amendment. We'll go ahead and put the amendment. Does the amendment make the bill?
Makes the bill.
Since it rewrites the bill, we'll put the amendment on the bill. All those in favor say aye.
Aye.
Any opposition? We're back on the bill as amended. You're recognized Chairman Terry.
Thank you again, Chairman Committee. Section 1 of the bill, some of the facilities that are specifically listed should fall under current statute, but we wanted to make sure that there was clarity over those facilities, including congregate living facility. And then secondly, the intent of the omnibus bill was to have visitation particularly pertain to COVID-19 patients. Therefore, Section 2 of the bill ensures that this applies specifically to COVID-19 patients. If it's the will of the committee, I would like to, if we can pass this on to full committee, if it's the will, there's a part in Section 2 that I'm working with the speaker on and to change the term terminal to critical. And that would be the only real change that we will be doing for that amendment.
Okay, do we have any questions or comments on the bill? And I would advocate for you being able to do that in between here and the full committee to make those alterations. Any questions or comments on the bill? If not, knowing that this is the speaker's bill, we will be voting to send this to full committee. All those in favor say aye.
Aye.
Any opposition? So approved. And we will move to item 2, House Bill 2662, also a speaker's bill, and I think Chairman Hall, you're recognized. Have a proper motion and second on the bill. Did we have an amendment? I think we have one amendment on it. One 4697.
That is correct, Mr. Chairman. Thank you. Yeah, drafting code 14697.
Okay.
Mr. Chairman, historically in the past, the Department of Health would hire the Executive Director of Pharmacy. House Bill 2662 would require the Board of Pharmacy to make that hiring. And with that, Mr. Chairman, I renew my motion.
The amendment has been explained. We'll be putting on the amendment onto the bill. All those in favor say aye. Any opposition? We're back on the bill as amended. You're recognized for further discussion.
No further comment unless there's any questions, Mr. Chairman. Thank you.
If none, we will entertain questions or comments on the bill. Not having any, we will be voting to send this to full committee. All those in favor say aye.
Aye.
Any opposition? So approved. We will move on to item 3. House Bill 2162 is brought to us by Chairman Eldridge. You're recognized on House Bill 2162. Have a proper motion and second on the bill. And I think we have an amendment on it. Would you?
Yes, Mr. Chairman, there is an amendment. It's 15048.
We're good on that. We have a proper motion and second on the amendment. Does that make the bill?
It does, yes, sir.
Okay, let's go ahead and put the amendment on the bill. All those in favor of the amendment say aye. Any opposition? We're on the bill as amended. You are recognized, sir, on the bill.
Thank you, Mr. Chairman, committee. This particular bill has come about, of course, it is an administration bill, and I do want to thank them for establishing an unlicensed facility strike force. And this came about last year in March when several state agencies were involved in investigating a couple of unlicensed facilities in Hamlin County. There were about 8 agencies involved, and it came to light that it wasn't sure exactly who was in charge. But this board establishes that the Department of Aging is working to make sure that some of our most elderly and vulnerable people are taken care of. And that's a short explanation, but that's the gist of it. It establishes it does establish a registry where these facilities are recognized so that the people can go to the website, see what the facility does, if it's been in trouble before. It also enhances some penalties for running an unlicensed facility after you've been placed on the registry.
Okay. Do we have comments or questions on the bill as amended? I'm sure that we have a great need for these unlicensed facilities, and I was very surprised to find out that we actually had them. And I think this is probably a wonderful bill to bring to light any discrepancies in the way that they treat their folks. So, yes, sir, you're
One
recognized.
comment, Mr. Chairman. Since this strike force was established, there's been 107 across the state that's been recognized as operating an unlicensed facility. And it's not that they're just keeping older people, they're keeping people with mental disabilities. It's a pretty wide range, and the situation there in Hamlin County just kind of brought it to light. And again, I do thank the administration for working on this.
Yes, sir. Thank you for bringing the bill. Have any questions or comments on the bill as amended? Question's been called. If there are no objections, we'll be voting to send this bill to full committee. All those in favor say aye. Aye. Any opposition? So approved.
Thank you, Chairman and committee.
Thank you, Chairman. We'll move on to item 4, House Bill 702. Let's roll a couple spaces. Okay, I don't see the sponsor. We will roll that down 2 spaces and hope to see them when they come in. We'll move on to item 5, House Bill 2156. I think Chairman Zachary, you're presenting that to us. You are recognized, sir.
Thank you, Mr. Chairman. Thank you, committee. Mr. Chairman, I do have an amendment, drafting code 014437.
We have a proper motion and second on the amendment. Does the amendment make the bill?
It does, yes, sir.
Okay, let's go ahead and put the amendment on if there are no objections. All those in favor of the amendment, say aye. Aye. Any opposition? So approved. We're back on the bill as amended. You're welcome to discuss it.
Thank you, Mr. Chairman. Now, members, this is an administration bill. It's a simple cleanup from some of the legislation we passed during the COVID special session related to county health departments. Just provides some clarity. Does 3 things in particular. Clarifies the Department of Health retains all authority in its mission for routine public health activities. Additionally, it addresses the health director. This legislation prevents confusion over disagreements between the mayor. The health director is appointed by the commissioner with advisement from the mayor. And finally, Mr. Chairman, this bill clarifies county health officer may continue to issue orders and make rules related to county health issues. Again, this is just clarification based on language that we passed during special session. With that, I'll be glad to answer any questions.
Okay, and thank you very much. It sounds like it does take care of some issues. Do we have any comments or questions on the bill as amended? If none, we will be voting to send this to full committee. All those in favor say aye. Aye. Any opposition? So approved.
Thank you, Mr. Chairman and committee.
Thank you, Chairman. We'll move on to item 6, House Bill 2801. I think that's yes, you're recognized.
Chairman, we need to roll that a few spaces till we get correct on the right amendment to go on that bill, please.
Okay, yes, sir. So no objections. We'll roll this for 4 slots here on the calendar. If you guys will keep track of that for me.
I have a different amendment than according to what we have on the list today.
Okay. Yeah, we'll roll you 4 slots. Is that okay?
Thank you, Chairman.
Okay. We'll move on to item 7, House Bill 2096. That will be rolled to the heel. If there are no objections, we'll roll that one to the heel. Item 8, 2171, House Bill 2171 by Chairman Terry. You're recognized. Motion. Have a proper motion and second on the bill.
Thank you, Chairman and committee. There's an amendment that makes this bill 15056.
Okay, that matches. We will, we have a motion and second on the amendment, and we will be putting that on the bill since it makes the bill. All those in favor of the amendment say aye. Aye. Any opposition? We're back on the bill as amended. You're recognized on the bill as amended, Chairman Terry.
All right, thank you, Chairman Committee. Federal law was updated in 2020 to allow opioid treatment programs to report to state prescription drug monitoring databases like our CSMD. So this bill will essentially line us up with federal law. And because inpatient treatment is part of a different program, the amendment that we put on clarified that inpatient treatment was not included.
Okay, do we have comments or questions on the bill as amended? If none and there are no objections, we'll be voting to send this bill as amended to the full committee. All those in favor say aye.
Aye.
Any opposition? So approved.
Thank you, Chairman and Committee.
Thank you.
Leader Lambert is here. We can go to item 702, or House Bill 702.
Leader Lambert has come in, and we have run again up on item 5, House Bill 2156. Oh, pardon me, that's wrong. Is it number 4?
It's House Bill 7.
Yeah,
item 4,
yeah.
702.
Item 4, House Bill 702. Leader Lambert, you're recognized.
Thank you, Mr. Chairman. And there is an amendment on this that should be coded 014996 that makes the bill.
Okay, we have a proper motion and second on the amendment. No objections. We'll be putting this amendment on the bill. All those in favor say aye. Any opposition? So approved. We're back on the bill as amended. You're recognized.
Thank you, Mr. Chairman and members of the committee. This on the surface is a very simple bill, but it deals with literally life and death circumstances. We've had obviously a difficult last couple of years fighting this pandemic, and there are some great treatments out there. There are some fantastic vaccines out there, and there have been lots of areas of our life that has affected. One of the areas that I did not realize this had affected till recently, a friend of mine in their district had a constituent who needed a kidney transplant. They had family members that were willing to be tested for that kidney transplant, and it would have been a known party to known party type transplant. When they went in to speak to the doctors about that, the individual that needed a kidney transplant is not vaccinated for COVID. They have made that personal decision on their own. Again, I'm not here to debate the strength or weaknesses of that particular decision on their part, but for their own personal decision, they have decided not to be vaccinated for COVID. Unfortunately, that decision apparently triggers within the medical community a decision on their part that if you are not vaccinated for COVID, then you may not get an organ transplant. Period. End of story. Even if it is a known party that is willing to give you a kidney. This bill just says that cannot be a consideration. So whether or not they're vaccinated for COVID is not a consideration that for organ donation or transplant would be something that would be considered. Every single other issue that they look at, seeing if that person is a good recipient, to see whether or not they would be compliant with what the doctor's orders are, which my understanding that's part of this. All of that they can still take into consideration. And I know I've talked to several of you on this committee. I was not able to get around and talk with everyone, but I know Dr. Kumar and I have had a very spirited back and forth on this, and he has an enormous amount of experience in this area. But just for this, I just don't think a personal decision on whether or not to be vaccinated for COVID should give you a death sentence on the fact that you cannot get an organ transplant. So with that, Mr. Chairman, I stand ready for questions.
Mr. Chairman.
Yeah. Okay. Yes. Representative Jernigan, you're recognized.
Thank you. Later, it's just COVID? No other vaccines?
Yes, you're recognized, Leader.
Yes, sir. Absolutely. I mean, any of the vaccinations, the ones that have been out there for years and everything else, all of those would still be appropriate. We are still, the scientific community, from my understanding, is still going back and forth on, natural immunities and COVID-19 vaccinations and which vaccinations work best. So just during this time right now, it is literally just the COVID-19 vaccine that would not be a consideration. Any other vaccinations would still completely be a part of that determination.
Chairman Jernigan.
You said just this time. Is there a sunset on that? If it comes to a point to where there is data and science that says yes, then what happens then?
Leader Lambert.
So this very specifically says for COVID-19, we obviously meet every year. There may be a time down the road when it would be appropriate to revisit this, but at this point in history, for right now, while all of this is still in turmoil, we should err on the side of allowing these folks to get a transplant and just say, look, if for whatever reason you've decided not to get a COVID-19 vaccination, then that's something that's not going to be a consideration on this. Now, it does not have a sunset, anything like that, but I will tell you, and I can only give you my word, that as long as I'm blessed to be in the legislature, I think this is something we should revisit in years to come if for some reason it looks like it's something that would be appropriate. For right now, I think these folks should be able to get an organ transplant.
Thank you, Leader.
Chairman, do we have other questions or comments from the committee? Dr. Kumar, you're recognized.
Thank you, Mr. Leader. Thank you for discussing it beforehand. And I see your point, but it's not a matter of a legislative decision. It is not a matter of discrimination against somebody or being prejudiced against a person who didn't get vaccination. There are medical reasons that a transplant would not be done. The point is, when a transplant is performed, the patient's body reacts to it that it has a foreign object or a protein. It can even come from a brother, sister, or mother where you think half the genes or number of the genes are same, but no, those people still react by body reacts by rejecting the transplanted organ. Only if there is an identical twin, and that's when the first transplant was done in the 1950s in Boston, they were identical twins, so there is no genetic variation. But in every other situation, even if it is a close relative, there is genetic variation. And once the body receives the transplant and reacts to it by trying to reject it, most of the time medically is spent on using medications to avoid rejection. It's important because what's the point of transplantation if the body is you're going to allow the body to reject it? So anti-rejection therapy is very important. What is anti-rejection therapy? It is basically immunosuppression. We're going to knock the immunity out of that person so they would not reject this foreign organ that has been transplanted in their body. If you have no immunity, you have no immunity. That means you're liable to infections than normal organisms that you and I handle fine in the atmosphere. But these people are prone to even the organisms that human race is used to living with. But no, those become infective organisms to these individuals. So they are very prone to infection. And transplanting an organ, you have to have immunosuppression. Suppressing their immunity opens them up to literally every infection. That itself is also a death sentence, no doubt about it, never mind the antibiotics. And the thing is that this is what we call, if people have other compromising conditions, this is the permanent compromising condition. And from that point of view, I can't believe that there would be a transplant program. Now let's look at COVID. Omicron is a relatively mild case. I had it after taking all the precautions over the years. I had it. I've had colds that were worse than that. But in an immunocompromised person, Omicron will be a serious threat. And that's the medical nature of the things. And for that reason, I think compelling or pushing or encouraging a physician, I don't think you'll find a transplant surgeon who would do so, because you have to immunosuppress them. No immunity means you're very prone to infections. I mean, normal organisms, as I said, that we handle day in and day out, are going to become a threat to life. And this point about just this time, just COVID, well, if it gets into our statute, so it's COVID today, the next time we'll come around and say, we did it for COVID. But I'm quite certain to you, certainly I can submit to you that it would be impossible to find a transplant surgeon or a transplant program that would do so. I would like you to kindly reconsider this, kindly think it out a bit, and if you want to take the summer to study the matter, I would join you. I enjoy every lunch I have with you, okay? So I would move that this matter is also a death sentence to a patient in whom going to give a transplant and do immunosuppress them. For that matter, it needs to be evaluated. I would move to summer study.
We have a motion to summer study. Do we have a second? If no second, we will proceed with the discussion. You're recognized.
Thank you, Mr. Chairman. And Dr. Kumar, you are a dear friend and extraordinarily knowledgeable in this area. I'm just asking for these folks to have a shot. I don't know if they'd have to isolate or do whatever is necessary, but some of these folks do have natural immunities, and we are all still working through how powerful that is versus the vaccine or in combination with the vaccine. In fact, the definition of fully vaccinated is still in flux. It seems to change by the day of how many shots are considered fully vaccinated and when. I'm just asking for these folks to have a shot. So the committee members, I would ask for a vote in favor of this bill to just at least say, for right now, we will put into the law that these folks, if they can find a surgeon, and Dr. Kumar may be right, maybe they can't, but I'd like to give them the shot at least to get that chance, to have that opportunity, and then take whatever precautions they possibly can, additional precautions, because it sounds like they definitely will need additional precautions, but I think it at least gives them a chance to have that organ donation.
Dr. Kumar, do you want to follow up?
Thank you, Mr. Chairman. No, I think the fact that there is not a second speaks for itself, and I can feel the cold wind. I'm really surprised because, sincerely, I think I've explained it. It just didn't. The leader has done more of an authoritative job of it, and thank you for the opportunity.
Congratulations, leader. Speaker Marsh, you're recognized.
Thank you, Mr. Chairman. And Leader, I would like to ask 2 or 3 questions. Is this happening just in Tennessee, or is it happening all over the nation? And do we have a national registry that lists everybody that's on the transplant, they're ready for transplants?
Leader Lambert.
And do they have best practices if they have a national registry?
So all fantastic questions that I have been asking of these folks. I initially thought, and this case came out of Williamson County, as where this individual had reached out to their senator, and that's how it came to be. Leader Johnson in the Senate has this. And we initially thought that this was probably just an isolated thing that dealt with maybe a few doctors at one hospital. It has since been communicated to us that apparently this is an issue for the national board that handles all of this, and this is nationwide becoming an issue. Each state is going to have to determine how they deal with this in each state. But it is actually one of those things that comes out of more of a national conversation on this. And I think it's perfectly fine for different states to handle it different ways, because what may be good for Tennessee doesn't work in California or somewhere else. But it is apparently a much larger problem than I first anticipated. I thought it was probably just dealing with a few people, maybe a few doctors at one hospital. But quite frankly, after Dr. Kumar and our conversation and tracking down a little bit more, it is apparently a nationwide issue.
Speaker Marsh.
Well, what if the doctor says he's not going to do it? I mean, I certainly wouldn't want a doctor giving me a transplant that said he didn't want to do it. I wouldn't want to make him do it.
Leader Lambert.
Yeah, there's nothing in here that makes them do it, and my hope is that if we put this in the law, there will be doctors that will be willing to work with that patient and just not consider this one sole thing. Consider everything else about that patient, take into account every other aspect that they want to take into, but just this one thing, just that, don't consider that thing. But no, there's nothing in here that makes a doctor, if every doctor after this wanted to say, look, I'm not going to do that surgery, there's nothing that makes them do the surgery.
Speaker Marsh. Okay. Dr. Terry, you asked to be recognized.
Thank you, Chairman. And to clarify something on here, the bill, it says that solely on the basis of vaccination status and the things that you cannot do, cannot consider an individual ineligible. Now, would that be, would the physician, could they not consider that person ineligible and not operate on them? The way that that's worded?
Leader Lambert.
So they cannot deny medical or other services related to the transplantation. But I'm saying it is not our intention in any way in this to say that's if they're going to do it. Okay, I mean, obviously, to the doctor's point, I mean, they don't have to do these. They can say, look, I'm just not doing it. I'm not interested in this case. Now, but they cannot consider that. It's similar to some of the issues that we passed last year, where we said, look, you can't take a adverse action against an employee solely on the basis of whether or not they're vaccinated. We're just taking that out of the equation. They can look at every single other aspect that they want to.
Dr. Terry, you're recognized.
All right, so I guess essentially the way that's worded, if I guess if a doctor was saying that they weren't going to do a transplant, they would just not say it's because your transplantation. They could say because your vaccination status, they could say what other risks that you had involved. Okay, and this is I asked to be recognized because this is one where it's a very difficult for me to be in, because honestly I agree with a lot of what you're saying, and I agree with the chairman of insurance. He knows a lot about this, and I've done anesthesia. Believe it or not, we have these type of patients as well. So another question for me. So say there's an organ that's coming from out of state, from Kentucky, Alabama, something like that. Are there standards elsewhere that would put limits on, or that would say that this may only go to somebody that's vaccinated? Do you know if that's something that applies?
Leader Lambert.
So I do know the answer to that question. So now we're in an area of law, which I know more about than the intricacies of practicing medicine. I trust you all that practice that on a daily basis to do that. Legally speaking, once that enters the state of Tennessee, that they would have to abide by our laws. And everything else you just said, by the way, is 100% true. The first point that you made, saying that a doctor basically is going to find another reason if they don't want to do that surgery. Yes, I mean, that's probably going to happen. It just can't be this reason. But yeah, I mean, once an organ or anybody, I mean, once you come into the state of Tennessee, you have to abide by our laws. Even if there is some other guidance or anything else, the only thing that would trump that would be a federal law to the effect that obviously that would trump state law.
Dr. Terry.
Thank you. So let me clarify this. So if an organ is in Kentucky and the procurement team is there and they're looking for people and they call Tennessee, and we have someone that matches, and they ask the question, is this patient vaccinated? And we say no, then they could turn us down. But once that organ gets to Tennessee, we could not turn them down for the vaccination status.
Leader Lambert.
Yes, our law does not go beyond our state borders. I mean, we can't control what another state's going to do. Now, I would hope and pray that if you've got an organ that matches up with somebody, that's, again, the whole point of this is to hopefully make this where that's just not the consideration. They look at everything they would have looked at before COVID. I mean, SARS has been around for years. This is just the most deadly version of that. It's why it's called COVID-19. We have a vaccination that, hopefully has helped and will continue to help significantly with this issue. And I have told people for now better part of a year or so that, I encourage folks to get vaccinated, but it is also a personal decision. So we can't control what happens in other states, but we can control here whether that sole thing is what's keeping somebody. And by the way, what really bothered me about this whole situation is it wasn't like in the particular circumstance where this came from, and maybe this is just this individual and their experience in the process, but that was like one of the first questions that was asked, and it's probably because obviously we're still in hopefully the last in weeks or months of a pandemic, but it was like the first thing they highlighted. And they said, oh, if you're not vaccinated, never mind. There's no need for us to go any further. We're not going to look at any other considerations. If you don't check that box, sorry, in essence, go home and die. That's just too much for me. I just feel like they should look at everything else, and just that one issue shouldn't be the trump card that kicks you out.
Dr. Terry.
Yeah, thank you, and appreciate your indulgence on this line of questioning. So in the event that the transplant surgeon in Tennessee knows that this patient has been a COVID survivor and ends up with organ failure or something like that, they could advocate on behalf of an organ in another state and say, I do believe, based on this person's natural immunity, that that me being able to take care of them with this is something that I could do and I could advocate for them. Is that correct?
You're recognized.
Absolutely 100%. And this bill allows for that conversation, because right now as a doctor, you could feel that, like, you have a patient who has natural immunity, you have a patient for whatever reasons, is able to undergo that procedure and to be able to take other measures to protect themselves after the procedure. And as a doctor that person's not vaccinated, but you're willing to advocate for them. That is exactly the scenario this bill sets in place, is that doctor is then able to advocate for that patient and say, here's why we still want to do this procedure. But it puts the power between that doctor and the patient's hands, instead of just a checkbox from somewhere else outside of this state that, like, hey, we're just not even going to go there.
Dr. Terry?
I'm good, thank you.
Dr. Kumar, you wish to be recognized?
Thank you. Just a few clarifications. One, the distribution of these organs is under UNOS, we call it, or United Network for Organ Sharing. These are people who are on the transplant list. Their antibody or antigens and their genetic information is maintained in this. When a kidney becomes available, they are by computer matched. Usually, it's best to go ahead and do it in the same area, but then again, depending on various rating systems, an organ may need to be transplanted. What you're mentioning is a living-related donor transplant. You're not talking where somebody has had a tragic accident or illness and they've died and we're going to take their organ. In that situation, so still the UNOS protocols do apply. And I have not checked with UNOS, but I'm quite certain that that would be a very firm part of the protocol. Also, it is not a knee-jerk reaction. We're going to just look at your COVID vaccination status and you don't qualify. Well, you don't qualify because that itself is sort of a deal breaker or a killer. You can have natural immunity. How long does that last? 3 months, 6 months? Organ transplant's going to be there forever. And again, situations going to come up where, as I said, Omicron is nothing more than a bad cold to a normal person. To an immunosuppressed person with no immunity, that could be very, very dangerous to a death sentence. So considering those circumstances, you look at number 1 point, if by that it is actually a death sentence to the patient, to go ahead and give them a transplant and then immunosuppress them, you stop there. You don't start investigating other things, because that itself is dangerous enough for the patient. And as I said, natural immunity does not last. Natural immunity can be very mild, because if you had a case of COVID that was very mild, you're going to have a natural immunity for a little while. It's going to be low level. If you had a very serious case, it's going to be a lot more, but yet it may last more than 3 to 6 months. Transplant's going to last forever. And sincerely, I wish you had checked with maybe the Vanderbilt transplant program and so on, and found out, well, is it really possible to do it? I think it would have been good to even have had a witness to come and testify, to explain to us all this that I'm saying about why we would not entertain the possibility. We will not go beyond the first step and investigate the other matters. Thank you, Mr. Chairman. Thank you, Mr. Leader.
Leader Lambert.
And thank you, Representative Kumar, again. And again, you really said it better than I could have there. If you don't get past that first checkbox right now, you don't even get to investigate whether or not a family member or anybody else can give you an organ. I mean, if you don't check that box, the answer is no, it's not going to happen, period, end of story. And the exact same issue that we are all struggling with COVID-19. Look, if somebody had this figured out, I don't know why they're being quiet about it. I mean, it is a difficult thing. We've all struggled through worldwide with this. The vaccinations, the same issue has happened. I mean, how long do they last? How long does that immunity last? You obviously can still catch COVID after getting a vaccination. Seems to indicate that it's less in severity, but we're still working through all that. Again, I just want these folks to have a shot to be able to get an organ. So, again, deeply respect you, but just not checking that one box should not kick somebody out.
Dr. Kumar. Okay.
Thank you, Mr. Chairman. Well, that box is important, because if that box itself is puts the patient at a very high risk of death, then there is no point going beyond, really. Thank you, sir.
Yes, sir. Chairman Hall, you're recognized.
Call for the question, Mr. Chairman.
Any objections to calling for the question on the bill as amended? If none, we will be voting to send this amended bill to full committee. All those in favor say aye. Aye. Any opposition? The ayes have it. So approved.
Thank you. Thank you, Chairman and members of the committee.
So item 6.
Okay. We will move to item 6. I think Chairman Sherrill or Leader Sherrill, you were recognized on item 6, sir. That's House Bill 2801, and I think you have an amendment
Yes.
that makes the bill.
Thank you, Chairman.
I'll stand for a motion. We have a proper motion and second on the bill. I ask for a motion and second on the amendment. Have a proper motion and second on the amendment. We'll put the amendment on the bill. All those in favor of the amendment, say aye. Aye. Any opposition? Passes. We're back on the bill as amended. You recognize Leader Sherrill.
Thank you, sir, Chairman. 014228 is the amendment that we're putting on the bill, which just is simply deleting rehabilitation centers and changing it to community-based vocational rehabilitation services, to advisory board.
Do we have questions or comments on the bill? If none,
I got one.
Yes, Chairman Jernigan, you're recognized.
Just wanted to, this is a good bill, and I just wanted to thank you for bringing it, and I'll support it.
Thank you.
Further comments or questions? Anybody want to be recognized? If not, we'll be voting to send this bill as amended to full committee. All those in favor say aye. Aye. Any opposition? So approved.
Thank you, Chairman and members.
We will move to item 9, which has been requested for a roll to the Hill. If no objections, we will roll that to the Hill. Item 10 by Speaker Johnson. You are recognized on House Bill 1976, and we have a proper motion and second on the bill.
Thank you, Mr. Chairman. House Bill 1976 exempts a veteran of the United States Armed Forces who is trained and certified as a medic or a corpsman from the initial licensure fee for the Emergency Medical Service Board.
Okay, sir. Do we have comments or questions on this bill? If none, we will be voting to send this bill to full committee. All those in favor say aye. Aye. Any opposition? So approved.
Thank you, Mr. Chairman.
Thank
Committee.
you, Speaker. We will move to item 11, House Bill 2705 by Representative Carringer. You're recognized on the bill. We have a proper motion and second on the bill.
Thank you, Chairman and committee members. House Bill 2705 simply allows municipalities in Tennessee to create smoke-free ordinances for age-restricted venues.
Okay, do we have any comments or questions? I assume this is the musicians bill that we're talking about. I think they've been around to see us. Dr. Terry, you're recognized.
Thank you, Chairman and Committee, and want to thank you for carrying this legislation. As someone that's an asthmatic, and I do want to talk a little bit about self-governance. That's something that, for me, is a big deal. And having constituents or having people bring bills, work their bills, and the individual that you're working with has done a fantastic job discussing this. I do. This is one of the issues that I've had with this bill as a whole. Has been the practicality of how this works, and I've advocated for doing an all or none, because my concern is that you have different counties are going to be different, and your even municipalities within the county may be different. But I've looked at is there a way to do this under TOSHA, and I tried to talk to an attorney to see if that was a way, and it's really difficult to get this. And my understanding of the all or none probably has less chance of passing. I do want to tell a little bit of why I'm an anesthesiologist, and it kind of goes along with the person that brought you the bill as a musician, you know, they have issues in these facilities, these age-restricted venues. You know, obviously, I'm an asthmatic as well, but I have no musical talent, so that limited me from being able to be a musician. But growing up as an asthmatic, I wanted to be a pulmonologist. And one of the things that when I was in med school, you know, you start doing your different rotations and such, and I could not physically be in a pulmonologist's office because of the secondhand smoke or just the smoke on people's clothes. I could not breathe. I'd get choked up. And so I'm very empathetic with this. I'm not sure where I stand on this bill. You've got a ton of support on this bill, and I think the ends probably justify the means. But there are some issues, I think. Commend you for bringing the legislation and working with the persons you're working with.
Yes, Representative Carringer, you're recognized.
Thank you, Chairman, and to my colleague, I appreciate your comments and having family in the medical field and all. I understand exactly. I am asthmatic also. Have a brother and a son and all, and I did sing, and it's very difficult when asthma is bothering me and all. So the musicians for a Smoke-Free Tennessee did bring this bill to me, and they are here also to speak if we need for them to speak. But from serving on Knox County Commission and from Knox County and, you know, having the city and Knox County separate, I know how hard it is to regulate something that's statewide, because each county or each city and all, you know, is different from others. And so I'm a big supporter of leaving it basically where our locals in each individual county and all can kind of make that decision as to what they feel is best. But again, we're looking out for the musicians and the others that are being affected by this. And so I think it's a good place to start, and I'd appreciate all the support that we can get.
If there, we will. You want go ahead, Dr. Terry. You're recognized.
Thank you. I appreciate that. I just want to make one further comment, and you brought this out, and this was something when I was looking at TOSHA, and I just want to make people aware of. I think it's like 5.8% of our GDP is essentially tourism and hospitality, and a lot of those people that work in that are exposed to secondhand smoke as well. So it's not just for musicians that would be impacted by this, and some of those folks, you know, they're in a job that it may be they're trying to go up the income mobility, or they may be in that job because on one hand they want to perform, but then there may be a struggling artist or whatever, and this is their job, so they can do their other job. And so I just wanted to bring that. That's it's a big part of our Tennessee industry. Thank you.
I'm good.
Representative, if not, Chairman Jernigan, you're recognized.
Thank you. Representative, love the local control. I'm not asthmatic, but my lungs are not my strongest asset either. When I pay for entertainment, I want to enjoy it. And I think this is a nice way of doing to allow the local control to do that. And it's a good bill, and I'm going to support it. Thank you.
Representative Carringer.
Thank you.
Yes. Any further comments or questions? Questions have been called. If there are no objections, we'll be voting to congratulate Dr. Terry on not pursuing a music career. Thank you, sir. You did better. No comments or questions. We will be voting to send this to full committee. All those in favor say aye. Aye. Any opposition? So approved. Thank you.
Thank you so much, Chairman, and to all your committee members. Thank you.
We are moving to item 12, House Bill 2250 by Chairman Vaughn. We have a proper motion and second on the bill. I think there is no amendment, I'm to understand, and I think you do have some testimony today. Do you want to describe the bill first, and then we'll consider testimony?
Yes, sir, I would defer testimony.
Yes.
If I can get my seeing devices out of my pocket. Thank you. Thank you, Mr. Chairman, and thank you, committee. We're here to talk, I usually like to joke around a little bit, but this is a serious issue that we're talking about today and addressing. It has to do with the involuntary commitment of people who are under mental stress and how that occurs within health facilities. It was brought to me by the Tennessee Hospital Association. I've brought numerous bills trying to deal with healthcare worker shortage throughout our state. We're seeing a diminishment of workers, which has the potential, I'm not saying that it does, but I'm saying it has the potential to diminish the amount of care that people need. And whenever somebody shows up at a psych hospital in distress, then that's when we need to have the resources to alleviate them and get them comfort. An involuntary admission occurs whenever a person poses an immediate, substantial likelihood of serious harm. This is included in state law. The person needs care, training, or treatment, or all available less drastic alternatives to placement in a hospital or treatment resource are unsuitable to meet the needs of the person. So it's my understanding that as of today, that a qualified mental health professional can sign sending someone to that into that situation, but currently a doctor is required to be the second signature for the commitment to get that person to be involuntarily detained and treated in the hospital. This bill proposes that we allow a qualified advanced practice nurse or qualified physician's assistant to make that second signature, with the caveat that they will be examined within 24 hours by a trained psychiatrist. As a result of that, we believe that people can get more immediate attention because these professionals, health professionals, would be on site, whereas the shortage of doctors is precluding that. And the way that I thought about this was pretty, it broke it down pretty simply for me, and that is, whenever an advanced practice nurse or a physician's assistant operates under the indirect supervision of a doctor, there's 30 days allowed before 20% of the charts are reviewed by a physician. This would be an almost immediate review of a qualified, certified mental health professional's judgment within 24 hours. But within that 24 hours, care could be provided, comfort could be given, and harm could be avoided. So again, whereas in one case, less drastic, notedly, 30 days is given for a physician to review decisions made by these people. In this case, it would be reduced to 24 hours. And that's the bill, and I'm here to answer any questions, or anyone can, or we can wait, and we have folks, I believe, to testify on both sides of the issue.
Any questions or comments? And if not, if there's no objections, we will allow you to introduce your, we'll go out of session, allow you to
And
introduce your
I'll
testimony.
allow these folks to introduce themselves.
Yes, sir. And we will give you gentlemen 3 minutes and invite you to go ahead and introduce yourselves. Yes, sir.
Good afternoon, Chairman Committee. I'm Joe Birchfield with the Tennessee Hospital Association. Thanks for having us here this afternoon. I'm joined by two guests who are going to do most of the talking for us, but just want to share what has already been stated, that THA supports this legislation that will resolve a persistent challenge in mental health facilities across our state due to that statewide shortage of psychiatrists, particularly a shortage in the hospital setting. This bill would leverage the training, experience, and qualifications of psychiatric nurse practitioners and physician assistants in the involuntary admission process. These clinicians already serve multiple roles in the evaluation and admission process as it stands today and in caring for all patients generally. This bill proposes to maintain the medical model of physician supervision of the qualified nurse practitioners and PAs while enabling more efficient and effective operations and care for patients who are in crisis. I am joined today by two physicians from Tennessee hospitals who can speak more directly to this issue and how the bill solves the problem.
Yes, sir. Please introduce yourself.
Thank you all for having me today. I'm Dr. Andrew Pierce. I'm a board-certified psychiatrist who works here in the state. As the Chief Medical Officer at Trust Point Hospital in Murfreesboro, I'm charged with safeguarding the compassionate, effective, and timely care of those members of our community in need of acute psychiatric services. As Tennessee continues to see a growing need for mental health service, it is necessary to identify new approaches to this care is provided. In my assessment, allowing qualified psychiatric nurse practitioners and physician's assistants to complete the second set of involuntary commitment paperwork on behalf and under the supervision of a psychiatrist will contribute positively to the delivery of vital services. Processing involuntary admissions requires assessing a person's immediate or substantial likelihood of serious harm and the need for care, training, or treatment, as well as confirming that all available less restrictive alternatives to hospitalization are unsuitable to meet this person's needs. Challenges with this process are particularly apparent during overnight shifts when there's limited availability of on-call psychiatrists. Psychiatrists completing these assessments are unlikely to be physically present in the hospital, often connecting remotely via telephone or video conference. This crucial task must occur at all hours of day or night, which results in a substantial burden to the psychiatrist tasked with its completion. It's my belief that the current system contributes to symptoms of burnout and dissatisfaction amongst members of medical staffs of inpatient psychiatric hospitals, as well as potential delays in assessment during this critical time for individuals in our care. Current state law allows qualified NPs and PAs, among other health professionals, to serve as the first of two required signatures on certificates of need for involuntary admission to a mental health hospital. Additionally, hospitals in Tennessee routinely use NPs and PAs for court hearings as experts to continue involuntary treatment where necessary in a particular patient's case. Enabling these professionals to continue to work within their training and qualifications can improve our ability to assist patients in crisis and improve patient throughput for emergency departments, law enforcement, concerned loved ones, and individuals while maintaining the long and honored tradition of allopathic medical practice, as well as providing support to help manage the current shortage of inpatient psychiatrists in the state. We're no longer in prior generations, and physicians now and in the future have an essential role in the global care management of patients and population health. In order to fulfill that role, we must involve qualified professionals such as nurse practitioners and physician's assistants, guided by engaged psychiatric supervision to ensure that all patients receive the timely care they need to return to a more normal and productive life. Subsequently, I would ask that you support this bill.
Yes, sir. Do we have a question from Chairman Hall? You're recognized.
Thank you, Mr. Chairman. Doctor, welcome, sir. Tell me what I'm missing here, because I don't think I'm grasping it. It only takes 2 signatures to take someone's freedom away when there's no crime that's been committed. Is that correct?
Dr. Pierce.
What it takes at this time for an involuntary psychiatric commitment is 1 signature from a qualified professional in the community. In our case, this is physicians, other social workers who have appropriate qualifications, or very importantly, law enforcement officers themselves. Upon recognition of a psychiatric emergency in the community by one of these individuals, a person can be detained until which time they arrive at a psychiatric hospital to then undergo that second opinion on their condition to understand whether or not involuntary commitment is appropriate. That second piece is what we're discussing today.
Chairman Hall.
Do you think that this would discourage people from seeking help under the threat of being apprehended?
I do not believe.
Dr. Pierce.
Sorry. I do not believe that this bill would change the current viewpoints on what's happening or materially alter how a person enters the hospital under an involuntary commitment, but rather shift the immediate responsibility, the timely responsibility of involvement to an NP who could be physically present, as opposed to a psychiatrist myself who may be evaluating them remotely.
Chairman Hall.
This sounds more like a staffing problem than a mental health problem. I know that in law enforcement, if there is you know, they would go get the judge in the middle of the night and sign a document if necessary. I'm having a lot of trouble with this to take someone's freedom away, even if it is just for 24 hours. When the individual is seeking help, voluntarily seeking help, but he's involuntarily apprehended, even if it is just for a short period of time. And then it affects the rest of his life. It affects his right to own guns. It affects his, whatever the case may be, his job history, his relationships after that. And I have a real strong, I'm not going to be able to support this bill, but thank you, Mr. Chairman.
Dr. Pierce, a response.
Yes, thank you, sir, for making those very valid points. A individual who is seeking voluntary treatment would not be impacted by this bill. And they would be allowed into the hospital on their own accord. This would address people who are being involuntarily committed, stating that they do not wish to be in a psychiatric institution, but however, that outside provider and then us in the hospital may come to the agreement that that is appropriate. And so that is part of that challenge.
You're recognized, Mr. Birchfield.
Yes, just a clarification on the removal of an individual's rights. It is my understanding that the second signature to admit someone to a mental health facility under this title does not take away those rights. Those rights are only forfeited under a court order, which happens within 72 hours to continue that involuntary admission. And so once the judge is involved is when that happens. It is my understanding that not the signature of a medical professional actually causes that to happen.
Chairman Hall, any response? Dr. Kumar, you asked to be recognized.
Thank you, Mr. Chairman. Thank you, gentlemen. I think Representative Hall addressed the matter. It's a staffing issue. So a person has an emotional breakdown or has a psychiatric condition. They are brought to a facility or a hospital, and they are, at first, they are evaluated by a physician or another professional who will evaluate them at the first.
Dr. Pierce.
At this time, it is only a physician that can complete the second signature, and that's the change that we seek to allow others.
Dr. Kumar.
Thank you. So a physician has evaluated them and felt that they need to be held or have involuntary confinement. And the second signature is required within 24, 48 hours. What is the need for that?
Dr. Pierce.
I'm sorry. At this time, the statute is as soon as possible, resulting in these evaluations occurring at whatever time a person may arrive at the hospital, oftentimes in the middle of the night.
Dr. Kumar.
Now, is that the first encounter or the second encounter? The first encounter?
That would be the second encounter. And so they would be seen in the community and initiated, then brought to the hospital for confirmation that involuntary commitment is necessary. And we're discussing that second encounter, sir.
Dr. Kumar.
Thank you, sir. The first encounter was in the community, let's say at an emergency room. And at that, there was a physician there, but not a psychiatrist there. Is that true?
Dr. Pearson.
For the first set, it could be a physician of any specialist, a psychiatrist, or some other qualified individuals, notably law enforcement, can enact that initial commitment.
Dr. Kumar.
Thank you. So they have been evaluated there, and a physician has signed off on the fact that this person needs to be further evaluated, but held at that time. Then they're at your facility, and it is necessary for a second professional to sign off on it, to hold them under involuntary commitment for whatever period of time is necessary. And what you're saying is that that second individual does not have to be a psychiatrist. It can be another mental health professional.
Dr. Pierce.
Yes, sir. Under the supervision of a psychiatrist, that is correct.
Dr.
So
Kumar.
kindly tell me the qualifications of the second person signing off. You said psychiatric nurse. Now, or nurse practitioner. Nurse practitioner is an RN with 1 to 2 years of further training to make them nurse practitioner. Now, have they also had additional psych nursing training, and is there a certification for psych nurses?
Dr. Pierce.
Yes, sir. There are specific educational tracks for specifically psychiatric nurse practitioners who all have obtained a master's degree or higher.
Dr. Kumar.
Are they so certified?
Dr. Pierce.
Yes, sir.
Okay. Thank you. Thank you for explaining that.
Okay. We have Chairman Jernigan. Let me take just a moment. I want to introduce Dr. Joseph Sharp, if you would introduce yourself.
My name is Dr. Joseph Sharp, and I'm a board-certified psychiatrist. I would like to also thank you for this opportunity to discuss the protocol surrounding the second set of 6404 committal papers. I currently serve as the Chief Medical Officer of Ascension St. Thomas Behavioral Health Hospital, and I'm also the Psychiatric Medical Director for St. Thomas Midtown and West, where I supervise psychiatric nurse practitioners. As Tennessee continues to see a growing need for mental health services combined with a shortage of psychiatric providers, a perfect storm is emerging. Physician burnout is increasing at an alarming rate, and unless some relief occurs soon, the shortage could become more dire. It is more important now than ever to identify new approaches that ensure appropriate, effective, and timely care to those in need. Challenges with the involuntary admission process at mental health hospitals becomes particularly apparent during day and overnight call when a second set of 6404 documents can only be completed by a psychiatrist or physician. This becomes more burdensome when there are 2, 3, 4, or more such evaluations needed overnight, which the psychiatrist is required to do. The same fatigued psychiatrist that will then need to see 20 to 25 patients the next day, making critical life and death decisions regarding pharmacotherapy, neuromodulation, or even placement issues. Qualified psychiatric nurse practitioners and physician's assistants currently are able to make the above determination and complete the first set of 6404 committal papers under proper supervision. It only makes sense to me that these physician extenders should be allowed to complete the second set of 6404 committal papers, again with proper supervision. Furthermore, any such action, the second set of papers, would be subject to follow-up review by the supervising psychiatrist as soon as possible and in no more than 24 hours. Enabling these psychiatric nurse practitioners and physician assistants to continue to work within their training and qualifications can greatly improve the timing of care delivery and more efficiently address the needs of the patient in crisis when every moment counts for patient and staff safety.
We've reached our 3 minutes. You want to close
Yes, sir.
quickly?
I just also want to explain that the bill would not intrude or infringe or detract in any way from the autonomy of the psychiatrist, but instead would improve the timeliness and efficiency and workload distribution.
Okay, thank you, Dr. Sharp, and welcome. Chairman Jernigan, you wanted to be recognized. You ask a question of any of the three, sir.
Yes. Thank you all for being here. And I grasp, I think, what's going on. And so the first signature, we go, and so we get to the second signature. This is a qualified person in mental health. And I think where I think that I lean in favor of this bill. And the question I want to ask you is, are there things within those 24 hours that second person can help facilitate some help for that person? Whereas if they weren't there, they'd just be waiting 24 hours for a doctor to show up?
Doctor?
Does that make sense?
Choose somebody. Yes, Dr. Sharp?
Yes, so that circling back in 24 hours does allow for more time to gather collateral information while establishing the safety for the patient. Patients in this scenario are kept in a waiting room that may or may not be very comfortable, and they're in a strange place. This bill would allow them to be quickly placed in a more comfortable environment, the ward where there's a bed, where there's food and drink, and then it gives us 24 hours to then circle back on that second set to ensure that everything was done the way that it should be.
Okay.
Chairman?
Yes, I like that part. I think Representative Hall was talking about someone who voluntarily comes in and they come in, maybe they've had some sort of panic attack or whatever, they come in. And the first person, I guess, to sign off, because I guess during the interview, maybe they say some alarming things that are harm to themselves or to others, which triggers, okay, it's not safe for this person to go back outside. So that would be the first signature. And then I love the second aspect. And I do think out of the two signatures, a psychiatrist does need to be involved. And what I'm hearing, they are involved.
Correct.
We're just giving, I think, comfort and aid in those 24 hours of someone, because it's based on medical evidence that you're seeing in real time, correct?
Dr. Sharp?
Correct.
Okay. Thank you for answering my questions, and my further questions will be for the sponsor.
Yes, sir. Dr. Terry, you requested recognition. If not, do we have further comments or questions? Yes, Speaker Marsh, I'm sorry.
Thank you, Mr. Chairman. And Dr. Sharp, is this the scenario that, the way I see this, that they're signed off to come to your facility, they don't want to be there, but when they get there, there's a qualified physician's assistant or a nurse practitioner that you all are saying could let them in, but what the other side's saying is they want them to have a doctor to sign for them to come in. Does the doctor approve this by telephone, or does the doctor come in and actually see them?
Dr. Sharp?
So that is usually done by telephone and video. It's a video call in the middle of the night, which can vary in quality, as we've all seen with the internet and glitchiness that can happen. What this bill would help provide is a real person that is there when the patient arrives to address the questions being asked, and under the direct supervision of a psychiatrist.
Speaker Marsh?
So in other words, you've got a person there actually looking at them that is trained, but not as much trained as the doctor, or the doctor doing it over the telephone. So I think it sort of makes sense to do it like this, as long as they get to see that doctor within 24 hours.
Dr. Sharp?
Yes, sir, that's exactly the way that I see it. And as it is now, those qualified nurse practitioners are very capable and able to do that to the first set, and there's never been an issue with that.
Thank you very much.
Further comments or questions of our witnesses? If none, sir, we appreciate your attendance here, appreciate the information. And we have a request from a committee member to have further testimony from the Tennessee Medical Association. Our good friend Julie Griffiths is coming. You're welcome to come forward with your expert and identify yourselves. You will have 3 minutes as well.
Julie Griffin, Tennessee Medical Association.
Dr. George Matthews, Tennessee Psychiatric Association.
Yes, sir.
If it would be okay with the committee, I would really rather Dr. Matthews testify first. I think that his testimony will be probably most valuable, but then I want to just put some bugs in your ear after he has completed his testimony.
Yes, Dr. Matthews, you're recognized.
Mr. Chairman, sir, honorable members of the State Health Committee, good afternoon to you. I'm Dr. George Matthews. I'm a hospital psychiatrist who regularly takes call at one of the largest psychiatric facilities in Tennessee. I'm also the president of the Tennessee Psychiatric Association, and I thank you for this opportunity to speak to you in opposition of House Bill 2250. I want to state that perhaps especially Honorable Member Jernigan may have been misled by some of the responses that you just heard, and I would like to come to that in a bit. But in the limited time that I have, I wish to suggest that this bill is really a guise to undermine signature authority. This is a bill that undermines signature authority. According to Tennessee law, as has already been stated, the second certificate of need can only be signed by a psychiatrist or a physician at the facility that they are being admitted to. I want to state that this bill does nothing to affect the timeliness of service nor the service. And I also want to state that this bill would actually result in the patient not being seen by a psychiatrist in person or by video for up to 24 hours after they are involuntarily committed. So I want to argue against that. Let me draw a quick parallel for you. As honorable representatives of the Tennessee House, you sign documents regularly, and once your signature gets on the document, that document has gravitas. That weight that the document has is because of the signature authority that is invested in each of you. Suppose a bill was presented stating that, gosh, there are fewer than 100 state representatives in Tennessee, and there are so many bills to be passed, and all of you are so busy, and all of you could do with some rest. Therefore, let's assign the signature authority to some other state employees so that you get rest and you will have time to review that subsequently. That clearly would be unacceptable to you. And I would suggest that that is what this bill suggests, and therefore urge you to reject it. I recognize that I had two of my colleagues present to you a few minutes ago, and it brings to mind a biblical analogy of a brother named Esau who sold his birthright for a pot of stew. I want to suggest that there are psychiatrist brothers and sisters who are willing to sell their signature authority for the comfort of an easier night or for the approval of the employers who have hired them.
Yes, sir. Your time's running out, but I didn't want to mess up that analogy. Do you have a closing statement, sir?
Yes, I want to state that this bill does not affect the service to the patient, which is our primary concern, and it's much more likely that the patient gets attention if a psychiatrist were to interview this patient before admission than is allowed to wait for 24 hours to see the patient after they are admitted.
Yes, sir. Dr. Terry, you wanted to be recognized. You have a question, then I'll let Ms. Griffin put her bugs in our ears. Okay, yes, you're recognized.
Putting bugs in your ears probably was not the best analogy if I'm wanting some support on my side.
It's much better than letting the staff sign our legal documents. That put a chill in me.
First and foremost, I want to make sure that everyone on the committee is aware this is not a scope of practice fight. And I don't want anyone to believe that we are sitting here because we oppose this on a scope of practice level. Tennessee Medical Association and the physicians of the Tennessee Psychiatric Association are here because we do believe that there is a patient rights issue that needs to be discussed and discussed in detail. Several years ago, before you could involuntarily commit a patient, it required 2 signatures from a physician, one on the front end and one on the back end. And it was agreed upon years ago, we would allow for there to be a physician on the front end or a designated individual, which could be a physician, but it could be a nurse practitioner or a physician assistant, or it could be a crisis counselor to sign that first signature. So that on the back end, you would get that physician's signature. Now we're back here to eliminate the second signature. Now, I know that there's a 24-hour window in which that physician would have to come in and see that patient. But the problem is once that second signature goes on there, you will carry an involuntary commitment. It may not be through a judge, but you will carry that involuntary commitment with you for the rest of your life. If you are ever asked if you've been involuntary committed, you're going to have to say yes. You're in a divorce proceeding. You are in a fight for your children. That could carry with you for the rest of your life, and a physician didn't, and even if the physician comes in within that 24 hours and says, no, I do not believe that they should have been committed, they still were committed because it got the 2 signatures and neither one was a physician. It is our strong belief that a physician, if you're going to take someone's rights away, and it does not have to be a psychiatrist, it just has to be a physician, that there should be a physician involved in that decision. And that is the position of the Tennessee Medical Association, and we hope that you all will be willing to support us on that.
Dr. Terry.
Thank you, and appreciate your comments on this. And and I kind of liken this a lot to the way that you presented it there to EMTALA, and you're transferring. And so on one end, what you said doesn't have to be a physician, but you are going to a higher level of care. And at that higher level of care, you are extracting freedom and liberty from that individual. And that higher level of care needs to be a doctor, in my opinion. I have a question for Dr. Matthews. Have you ever been called or to be asked to be on call at night and ever not taken it?
Dr. Matthews?
No, sir.
Thank you. I'd just like to give you guys because I think most of the people out there in the committee know that I usually I have a process sheet for this, and the process, the first thing is what's the premise or what's the problem that we're addressing, and it appears that the premise, or they're looking at potentially, is there a shortage? What is the need? Would you address what that premise would be?
Ms. Griffin? Dr. Matthews?
You go ahead, and then if you'll let me speak after that.
Dr. Matthews?
Yes, there is a relative shortage of psychiatrists, and we welcome the addition of nurse practitioners and physician assistants to the team that helps serve our patients. The issue here is whether they should have that signature authority for involuntary commitment when they first present to the hospital.
Ms. Griffin?
To me, in my opinion, if we're having situations where you have employed physicians or contracted physicians who are partly in their contracts or in their employment agreements have said they are going to take call, and they are not doing so within a timely manner, to me, that's a problem for the employer to be putting pressure on their employees, not bringing something to the General Assembly and asking the General Assembly, well, let me not have to be mean to my doctor, and you all just fix it by taking people's liberties away. That's the way I view this. If there's a problem with doctors not taking the call, the employer needs to be either one, taking action against that employed physicians, or that contracted physician. And again, it does not have to be a psychiatrist.
Dr. Matthews?
I want to echo what Ms. Griffin just highlighted. this bill was presented without consulting the American Psychiatric Association or the Tennessee Psychiatric Association. We were informed about it just a few weeks ago, and since then, we have invited the Tennessee Hospital Association to work with us on an alternative which would help solve the problem. And we are talking with the national board, the legal system, to craft a better bill that would solve the problem. But here we are debating this bill right now.
Dr. Terry?
Thank you. And to go down my process sheet, number 2 on that list is what are our goals? And to me, obviously, it's to treat the patient, ensure that they do no harm, to ensure that there's no harm done to that patient. But I would also submit that protecting their freedom, protecting their liberty, ensuring that if you are going to involuntarily commit them, that those processes, that there's somebody there, a physician's signature on that. And I would like to point out that when we have emergency surgery and the patient is either out of it, on one end, I have the surgeon sign the consent, and then I sign the consent. And so we both sign the surgical consent and the anesthetic consent, because we're about to cut a patient open. And that's something that I take that very personal, that if you're going to extract something from a patient, that you need to have that level of care. So then that gets the third thing, what are our options? You say there are other options potentially out there. I would submit that this option does not meet all those goals that I would like it to meet. But thank you for discussion.
Yes, sir. And let me take a moment here. We are out of time. However, Representative Freeman had asked to be recognized. Is there a will of the committee to go back into session and vote on this issue, or do you want to extend it to the next meeting? Questions of the testimony? If not, we will. Okay. If there are no objections, we'll go back into session. Oh, yes, pardon me. Yes, go ahead, quickly.
Thank you, Chairman. I appreciated hearing my colleagues' comments about the process, because I have a similar one, and sometimes I feel like we hear squabbles between administrative level that is not necessarily best for patient care. And my question is, what happens today if there isn't that second physician to sign? Is that person released even if they're believed and brought in because they feel like they're a danger to themselves?
Witness. Dr. Matthews?
And my second question to that is, do we have any idea of how often those people are released without getting treatment because there's not a physician on staff to
Dr. Matthews?
Okay. All of the psychiatric facilities to which a patient may be involuntarily admitted does have psychiatrists on staff and does have psychiatrists on call 24/7. So there is a psychiatrist available. The question or the suggestion here is, let's have somebody else do the second certification while the psychiatrist gets to rest. I'm a psychiatrist who till recently took call 2 nights a week, and I want to say that it is being done, and it is being done adequately. But this is, again, an attempt to undermine that signature authority. I know we're out of time, but do I have the time to present an example?
I think, does that answer your question? I think the representative is satisfied. And do we have further comments or questions of our testimony witnesses? If none, we will go back into session. Thank you so much for the information you shared with us. We're back in session, and we will recognize Chairman Hall.
Thank you, Mr. Chairman. It seems that there's a lot of unknowns and there's a lot of unanswered questions. I would like to respectfully ask the sponsor from Shelby County to withdraw this bill and send it to summer study and then revisit it on another day.
Are you making that as a motion?
Yes, sir.
We have had a motion to Refer to summer study. I'll recognize Chairman Vaughn.
Well, I didn't know that I got a chance to withdraw it if it's being motion to go to summer study, but I think it's kind of fascinating conversation that we've had here today. You have operators of facilities that see real live patient people in distress versus, and I'm usually a TMA, I agree with TMA on more issues than not, but I find the TMA in the middle of a turf battle and saying that people can be examined over an iPhone and it's equivalent to having another human being in the room with them make a reasonable decision on it. So obviously I stand at the will of the committee. I'm at this point in time, withdrawing the bill kills the bill, so I'd just assume the committee vote on it.
Okay, do we have a second on that motion? Chairman Terry makes the second. Any discussion or comments? If not, we'll be voting to send this bill to summer study. All those in favor say aye.
Aye.
Any opposition? So approved.
All righty, thank you.
Thank you, sir. We will stand for a motion to adjourn. Oh, the remaining balance of the bills will be rolled till next week's calendar.
There we go.
So we'll stand for a motion to adjourn. And I want to let the audience know that this is an hour-and-a-half committee. So at 1:30 we have to close down. Thank you very much. The motion to adjourn. All those in favor, so approved.